The subject matter here is pharmacologic management of hemorrhage. In a 30-minute talk, I thought it was best to actually go into some detail on one element of that, the one that's probably gotten the most attention in the United States. I have no disclosures, perhaps other than to say that there will be nothing in this talk that I will describe as my favorite citation of all time, not once, much less twice. I'm going to go over non-obstetric applications of tranexamic acid, since I think that's where the great bulk of evidence is out there in support of its use. I'm going to talk about some of the limitations of trials that exist in obstetrics. I want to talk a little bit and put this into the context, which I think is extremely important in the use of this therapeutic intervention, and that is the risk-benefit equation, which I think everyone's really struggling with this to some degree. And I'm going to talk a little bit about what is on the horizon that is probably going to inform our decision-making to a great degree. I think it's important to talk in anything in the context of management of, well, what we used to call transfusion management. Most people involved in this community who study this thought it was very important to actually change the name of this to blood management, since transfusion itself probably represents only one of 25 or so interventions that you should be thinking about in the realm of managing what you historically thought of as just being transfusions. In fact, many of these exist prior to needing a transfusion and preventing you from getting there. To talk about pharmacologic management, and actually this actually includes uterotonic agents. I'm going to talk about this very narrow one, that is antifibrinolytic therapy, and specifically tranexamic acid. There's a great deal of enthusiasm, particularly in the European community, not just about tranexamic acid, but fibrinogen concentrate. I think about 10 years ago, our community was very interested in a recombinant factor 7A, and whether this might be the silver bullet in managing obstetric hemorrhage for us. It really has not panned out to be that. Out of curiosity in this room, how many have given recombinant factor 7A in their career? Okay, I would say 2/3 room. How many have given it in obstetrics? Maybe about 5 in the room. Okay, so tranexamic acid is a synthetic lysine analog. The name of it comes from those of you who like to go with organic chemistry names, the tran, the exam, and the ic. There's no M actually if you look at the tail end there. It's a competitive inhibitor of plasminogen activation. It's excreted in the urine, which is going to be important when I talk a little bit about complications and dosing later on. You see the elimination half-life and then some subsequent infant feeding considerations, which generally are not significant. As I mentioned, in the bleeding cascade, this inhibits conversion of plasminogen to plasmin and has some subsequent role also in modifying that cascade at the plasmin level. With reference to the blood management guidelines promulgated by the American Society of Anesthesiologists, to some degree, the recommendations we made as that work group about 3 years ago now, there was still accumulating evidence, and there was certainly very limited evidence in the setting of obstetrics, but you'll see, and I'll provide some of the background discussion on what we talked about with regard to the recommendations that we would come up in this sphere. Just to give you a remind you of the grades of evidence. Interestingly, outside of obstetrics, the majority of the evidence here is in the highest tiers of evidence, the categories A1 and A2. Specifically, the recommendations we made in those guidelines published in 2015 were that both for, that there was grade A1 and A2 evidence both for the reduction of blood loss with the use of prophylactic tranexamic acid, and there was not an increase in complications, serious complications associated with its use. Note that of all of these meta-analyses that existed in the fall of 2014, that none of them really, actually there were a few that had just come out at the time this was being assembled. Almost all of this was coming from cardiac literature and other clinical domains. But clear evidence of reduction of blood loss, without increase in stroke, myocardial infarction, or death. That being said, what does one do with the limited amount of evidence in obstetrics when we know that our patient population is, yes, at high risk for hemorrhage, but also is a prothrombotic group of patients? The language that came out of these recommendations, yes, endorsed their use in cardiopulmonary bypass and joint replacement surgery, but you'll note that we were careful to choose, in considering other high-risk scenarios, consider giving an antifibrinolytic in that setting. We are concerned enough about whether this would be more broadly interpreted and widely adopted in obstetrics, given the fact that we weren't entirely sure at that point whether the risks of its use in this patient population would warrant its broad use. So we put a qualifier in there that said, exercise caution in the setting of an obstetric patient. That was regarding prophylactic tranexamic acid use. This, with regard to therapeutic tranexamic acid use, where I think many experts within our field probably feel more strongly about its use in this setting. That being said, there's very little evidence to support it. As you know, it's difficult to conduct research in obstetric patients to start with. It's even more difficult to conduct research in obstetric emergencies. In fact, some of the trials that have addressed therapeutic administration, probably one of the biggest shortcomings is many people feel that they actually randomized and treated them therapeutically with a lower level of hemorrhage, that many of the effects that could have been shown were not shown because these patients weren't sick enough, so to speak. Outside of obstetrics, in the orthopedic and cardiac communities, people are referring to this as starting to think about it as terms of a silver bullet, pharmacologic management of hemorrhage. This is a list of several other clinical domains and the odds ratios of pooled trials in terms of reducing blood loss. And as you can see, pretty substantial evidence, but you don't see obstetrics on the list. One trial in gynecologic surgery. And also, specifically to address the orthopedic literature, which seems to be a very strong endorsement of the use of prophylactic tranexamic acid, there might be a slight bias in the published literature to suggest that, or at least to suggest that there maybe have been publication bias. This is a funnel plot. You'll note as you rise within the pyramid of a funnel plot, you move from smaller to larger trials. The top of that pyramid should be centered over the average effect size. What you would see normally is that dots on this representing individual studies and their size should be spread out symmetrically towards the bottom of this funnel. The fact that you see missing dots on the right side of that lower trial suggests that small trials that were negative, that did not favor the use of this intervention, were not submitted. So you probably get some slight bias in the published literature to suggest, which could in fact exaggerate the published effect or the cumulative effect. Also note up there some problems that exist not just in the orthopedic literature, but also exist throughout the entire published tranexamic acid body, is that allocation, concealment, blinding was missing. In this case, it's the green dots as compared to the white dots in a great number of these trials. The largest trial on tranexamic acid existed within in the trauma literature. 20,000 patients randomized to receive tranexamic acid or not in transport to an emergency room, and the primary outcome being death. And they showed a significant reduction in death. Very rare that we're able to show that as an outcome, but the death rate was reduced 1.5% if you look at the 16% death rate in placebo to 14.5% rate in tranexamic acid. And surprisingly, there was a there was no difference, although one might read a trend towards a difference in thrombotic complications. But surprisingly, it appeared that there was lower rate of thrombotic complications in the group that received this antifibrinolytic therapy. When one talks about both the prophylactic or the therapeutic use of a new medication in a setting where we have limited resources, this is a setting, therapeutic use of tranexamic acid almost certainly will make sense in terms of cost effectiveness. If you look at standard doses people are using in the United States, the oral agents are used mainly for outpatient management of menstrual bleeding and other indications. Mostly what we use in our setting is intravenous, and it's usually 2 times that bottom price tag there for a single therapeutic loading dose and probably an hourly infusion dose. So almost certainly in a therapeutic intervention it's going to be cost effective. That being said, if you're adding this cost to every single cesarean delivery you do, it might not meet that threshold. When you talk about cost effectiveness thresholds, we usually talk about ICER ratios, and that is what is the incremental cost of this intervention, and what improvement do we get from this. I'm going to back up here actually. It does include broader quality of life measures, not just some of the things that we typically will include in simple cost effectiveness analysis, and $50,000 per quality adjusted life year saved is usually set as this arbitrary threshold. Almost certainly therapeutic tranexamic acid will probably fall under that, whereas prophylactic may or may not, just to be aware of it. I think Dr. Scavone in the last lecture described some of the unique features of obstetric hemorrhage with regard to activation of clotting factors. Not entirely well known. It's not that well studied within our field, but we know that it's very different. If you lose 1,500 mLs of blood in an obstetric patient or 2 liters, you know that you're treating coagulopathy much earlier than you would be in an otherwise healthy trauma patient who is not pregnant. There's much earlier fibrinolytic activity as seen. We know that from some studies, and I'll show you a single study out of France demonstrating some of these measured traditional coagulopathy values. At no point in this study do I, in this short lecture, do I address any of the use of more dynamic measurements of bleeding, which could include thromboelastography or elastometry. This is just use of traditional laboratory measures. This is an observational trial of patients who had obstetric hemorrhage as defined by more than 800 mLs of blood in a vaginal delivery, and were used a non-hemorrhage control group to look at traditional measures of bleeding. On the left, you'll see fibrinogen levels in her study, and on the right, you'll see D-dimers as a measure of thrombolysis. Most importantly in this paper, though, was that after 400 mLs of blood loss, this group received a 4-gram load of tranexamic acid and a 1 gram per hour maintenance dose, which by many standards and people who are currently using this therapy would consider a very high dose. What it demonstrated is, if you'll look on this graph, at inclusion in this trial, they had tranexamic acid administered, and within a few hours you saw a difference between patients who had received this or not. I'm sorry, this was a randomized controlled trial. I said observational. Patients were randomized to receive either tranexamic acid or a placebo at 400 mLs of blood loss. And those that received it had much less fibrinolysis within a few hours, suggesting and demonstrating what the mechanism of this, or at least part of what the mechanism of this therapy is. 5 years ago, as we started to look at this, and this got the attention of the obstetric anesthesia community, there were a handful of randomized controlled trials. It looked like they were trending towards showing a cumulative beneficial effect towards their use. But I think the important thing in 2011 as we looked at this, and as certainly our group looked at it, we expected the next trial would probably have a meta-analysis positive effect, which in fact it did. But there's two things. There's one, there's an effect, and there's an effect size. The problem, even at this time, was that, yes, it could have been used prophylactically in a cesarean delivery, but it's probably going to save you only a small amount of blood loss, maybe 100 mLs, 150 mLs in some meta-analysis, or less. That was a little bit hard to justify, both in terms of its unknown risk of thromboembolic complications, as well as some of the cost considerations for a prophylactic implication that I had mentioned earlier. 5 years down the road, there have been a large number of trials that have been published. They have demonstrated the meta-analysis of these together would almost certainly demonstrate a beneficial effect, but again, look at the effect size of 12 trials. If you give a prophylactic dose for every cesarean delivery, you will on average save 78 mLs of blood loss. Another group, a subset 4 of those randomized controlled trials, demonstrated that you could actually, by another definition, reduce major hemorrhage or hemorrhage over 1 liter in a cesarean delivery. Both of those would appear by a traditional meta-analysis to be a beneficial effect. That being said, there's something more behind the scene in this pool of literature. It's actually a little bit unusual, but not entirely unprecedented in clinical science. If you break this down and look at 11 or 12 of these trials, a great number of them have some aberrancies. Look at this language used that I've highlighted at the bottom. 4 of these were trials that had text similarities, whole pieces of them cut and pasted. What exactly is this about? In fact, if you look at it, not just in terms of the estimation of blood loss, it also appears in some of those with who looked at it in terms of the definition of whether you need to transfuse or not. Many of these trials were done, I think it's a phenomenon that I've observed as a reviewer, that many training programs internationally have a requirement that you need to do some kind of scholarly project. And interestingly, tranexamic acid is a fairly easy one to do, mainly in terms of you can demonstrate a statistical difference with smaller numbers than a lot of clinical trials. But if you dig into these a little bit more thoroughly than just looking at it quantitatively, you'll find that there's a great deal of qualitative concern in these trials. Just like in the orthopedic literature, a great deal of them, there's concern about true blinding. There was also several of them missing research and ethics oversight. In the end, this author, Kerr, did not put a diamond at the bottom of his meta-analysis. He had such concerns about the methodologic and quality and ethical problems that he felt that he couldn't pool data from this group. Just to give you some sense of what's going on. I think Steve Schaefer, our former editor-in-chief of Anesthesia and Analgesia, highlighted very nicely in an editorial that he wrote about plagiarism. He described at the end of his tenure term as editor-in-chief as really it was an eye-opening experience in how much there is, and what this would fall into is what he categorized plagiarism for the scientific language. He said in many countries around the world, it is actually considered respectful to copy methodology from other scientists, whereas many others consider that fraudulent, so to speak, so that there are some cultural differences here. But more importantly, I think the real problem he had as an editor is he said if someone really can't understand what they're writing, their published work in, then you really have to be skeptical about the conclusions they're coming to. And it really leaves this body of literature questionable. To put this in a broader context in terms of maternal mortality, both whether it's defined in the United States or globally, the CDC's data, listing, it's really interesting how far hemorrhage has come down that list in the most recent CDC evaluation of hemorrhage, of maternal mortality. In fact, tomorrow I'm going to show you in a provocative talk what's missing in that list and what I think should be at the top of that list, but goes unlisted. And globally also, trauma is not listed in the CDC data either. But these are two leading causes of maternal mortality. There's no doubt about it. If you look at the purple bars, the most recent time period in the causes of maternal mortality, you'll look at the incidence of hemorrhage and thromboembolic percentages of death, are pretty similar. In handling any decision-making in a clinical realm about coagulopathy, you are manipulating a very subtle balance between these two things. I think our goal overall is to drive down mortality in both of these categories, but it's quite possible, and it's one of our concerns, that we could drive down hemorrhage deaths only to increase the bar in thromboembolic deaths. What is the real thromboembolic risk in pregnancy? Well, it's 4 to 5 times that of those of us who are not pregnant. What is the absolute risk? Some thromboembolic complication occurs in about 1 in every 600 pregnancies, but not all of these are fatal. But the fatal ones are about 1 in 100,000. Interestingly, the greatest odds ratio risk in this realm for thromboembolic death occurs in managing severe hemorrhage. What does that tell you about it? It might suggest that a great deal of our enthusiastic response to treat hemorrhage, we might be over-treating the coagulation portion of it and actually putting patients at greater risk. Now, that's a very difficult thing to say to someone who's managing an emergency, a hemorrhagic emergency. But I think this clinical case that's about to be published, it's EPUB ahead of print in ANA, demonstrates some of the risk balance framing that we use. This was a case, a primiparous patient who is being managed for a cesarean hysterectomy at 34 weeks, which we have identified as a smarter choice in terms of timing before the placenta is even more invasive into the abdominal cavity. This group decided to use hypogastric artery balloons, which are controversial, something we talk about in obstetric hemorrhage, whether they should or should not be used. And they also, on top of that, did the additional step of using a prophylactic tranexamic acid bolus and an infusion to follow. The blood loss was nominal. The case was fairly straightforward. It was the post-operative course that was problematic. Profound bilateral aortic iliac thrombosis that had to be managed interventionally, giving you some suggestion that, again, this is a fine balance. It is a risk-benefit. Here is a case where they blew up the balloons and stopped flow to the lower extremities, but also were administering a procoagulant and ended up with a severe complication. There are several other complications out there. When you start looking at, yes, this might be beneficial to give prophylactically and get a small benefit from it. Maybe it's beneficial to give it as a rescue when you're in severe hemorrhage. Probably many of us would do this. But there are some complications that are popping up in the literature in subtle corners, such as the American Journal of Kidney Disease, which I doubt any of you have ever cracked open. But I owe Alex Butwick for identifying this when we did a panel together last fall. France is a very enthusiastic group of adopters of tranexamic acid. Listening to Frederick Mercier speak at the World Congress last week about it, absolutely feels strongly about this use therapeutically and prophylactically. And they've used high doses, as I think I highlighted to you somewhere earlier in the talk. This is a case cluster of 18 patients in France who had received tranexamic acid as part of their obstetric management and had demonstrated permanent kidney injury due to thromboembolic disease of the kidney. We see a fair amount of acute kidney illness in a lot of our management and anesthetic, usually related to hypovolemia, hypotension, or the administration of some nephrotoxic drugs. We do not see, and it's almost unheard of, to see renal cortical thrombosis, renal cortical injury of the kidneys that is permanent and has left these patients requiring permanent dialysis. Really starts to give you some context about the risk-benefit here. One other, or I think two other things that I wanted to point out about it. Tranexamic acid is associated with a fairly high incidence of seizure in patients. This has been mostly identified in the cardiac literature where this is used profoundly, and I showed you our guidelines certainly strongly endorse the prophylactic use of it. But it does occur in a patient population that's at a little bit higher risk for the seizure complications with tranexamic acid, and that is specifically elderly patients are at higher risk for this. But tranexamic acid is a competitive GABA agonist, and it causes excitability, which, oh, that bottom image came out funny. Anyway, it showed the EEG differences between patients who were on tranexamic acid or not, and a difference in excitability in both of those groups. The graph that I put on the right stage demonstrates data from a single case of a vascular case where they had an intrathecal catheter to pull off cerebrospinal fluid to reduce the risk of ischemic injury to the cord. But they were able then to sample both serial serum and CSF tranexamic acid levels to demonstrate that this is something that doesn't cross the blood-brain barrier easily, but it does to some degree. There's a tenfold difference in concentrations between these two administrations. But that is probably relates to, it somehow gets in due to some other unknown mechanism of crossing the blood-brain barrier, and it can increase excitability of the central nervous system. It also tends to highlight another devastating complication of the use of tranexamic acid. Actually, it's unfair to refer to this, I guess, as a complication per se of this drug as much as systems errors. There have been about 12 cases of maternal death related to this drug error. These are vials of bupivacaine and tranexamic acid. As you can see, they look a lot alike. There is one space within the body that is about as unforgivable as there could be in terms of a drug error, and that is the intrathecal space. This case series, I guess, together should give you pause to how you administer your intrathecal doses. There is something profoundly unforgiving about giving this drug in high doses in the central nervous system. This is the data set we're all waiting for. It seems like I've given a lecture like this for probably 2 years now and have ended it talking about the anticipated results of the woman trial. This is the same group that's put out the CRASH 2 trial. 20,000 women around the world randomized to therapeutic use of tranexamic acid. So these are patients who are hemorrhaging. The primary outcome was death or a hysterectomy, and secondary outcomes I have listed there. The accrual in this study, as I mentioned, it came out with the same group, the London School of Hygiene, that have been really, and under the leadership of Halima Shakur, an extraordinary working group. Any of those of you in the audience who do clinical trials, it's staggering to think of the effort that goes into coordinating trials of this size. I showed you the results of CRASH 2. I'm going to show you what the woman trial is about to tell us. CRASH 3 is the same study methodology in traumatic brain injury, which we can anticipate the results of. And there's also a trial that's approaching completion of recruitment for GI bleeding and the use of this drug. The woman trial was initially powered for 15,000 patients to show a 90% power to show a reduction of 4% to 3% in this composite outcome of death or hysterectomy. They conducted an interval evaluation in the fall of 2014 that suggested that they were going to be underpowered to show a difference, which has raised a lot of eyebrows in the clinical science community, because almost certainly many people would consider that you would need to take a statistical penalty for 2 looks. Specifically, a 0.05 may not be fair. A 0.025 might be the better endpoint for this, but they extended recruitment to 20,000 patients, finished it last March, and we're all waiting publication. We don't know the results. There's some buzz out there what they are, but the reality is, unlike many trials, there's been no abstract published in this. We're anticipating publication will be the first we see of these results. So to conclude this talk, there is some benefit to the use of tranexamic acid prophylactically in obstetric patients. However, the effect size is very limited, at least to the best of our knowledge. Many experts feel that there might be some therapeutic advantages of using this drug in the setting of hemorrhage and more advanced hemorrhage. However, one has to be extremely thoughtful about the risk balance in using this pharmacologic management of hemorrhage. Almost certainly the woman trial results are really going to inform our decision making in this. However, given the setting that the study was done, mostly in third world countries, I think the biggest recruitment's in Pakistan and West Africa, we may have some decisions about whether it's generalizable for us. And there's certainly a lot of work to be done in the future. Thank you very much.